Hi, I am Peter Gloviczki from Mayo Clinic, Editor-in-Chief of the Journal of Vascular Surgery, and I am pleased to introduce to you the best papers of the March issue of the Journal of Vascular Surgery. The Editor's Choice article this month is the Western Vascular Society Guidelines for Transfer of Patients with Ruptured Abdominal Aortic Aneurysms, written by Drs. Mell, Starnes, Kreis, Schneider and Pevek. The authors make a point that when a patient with ruptured abdominal aortic aneurysm presents at a facility ill-equipped to provide care, transfer may provide the best chance for survival. Here are just a couple of guidelines to remember from this important document. 1. A clinical diagnosis of ruptured abdominal aortic aneurysm should be considered in patients over the age of 50 years presenting with abdominal back pain and hypotension, and with a known aneurysm and symptoms of either abdominal or back pain, hypotension, or impending cardiovascular collapse. Permissive hypotension is advocated for patients with a clinical diagnosis of ruptured abdominal aortic aneurysm to maintain a mental status and systolic blood pressure of 70 to 90 millimeters of mercury. This is a strong recommendation with a level of evidence that's of moderate quality. If vascular services cannot be provided on site, the guidelines recommend transfer to a hospital with appropriate facilities and expertise, including in EVAR, performed under local anesthesia. Again, this is a strong recommendation. Patients with prior good functional status without cardiac arrest or severe comorbidity should be transferred without delay. Transfer of patients, however, who are suffering cardiac arrest may be contraindicated, as such patients are unlikely to survive transfer and surgery. Patients with severe medical comorbidity, advanced age, and those who require significant hemodynamic support may be considered for transfer after discussion with the receiving vascular surgeon. Again, these are strong recommendations. A new and important guideline: patients who previously have declined or have been turned down for elective surgery should still be considered for transfer and treatment. Again, this is a strong recommendation. CT scan should be performed if it doesn't create undue delay in transfer. It is preferable for images to be sent electronically to assist in rapid operative planning. Again, a strong recommendation. In-transit care should include establishment of 2 large bore peripheral intravenous access, frequent and continuous vital sign monitoring, and permissive hypotension with gentle fluid administration to achieve a systolic blood pressure of 70 to 90 millimeters of mercury, and blood products during transfer are not required and they actually may delay transfer. This is a strong recommendation with a level of evidence that's moderate. And finally, a formal protocol for treatment of ruptured aneurysm should be in place for care of transferred patients to expedite care. This is a strong recommendation with a level of evidence that's moderate. The next paper from Boston and Lebanon by Zetterwall and colleagues is a fresh look on the effect of surgeon and hospital volume on mortality after open and endovascular repair of abdominal aortic aneurysms. This was a retrospective analysis of prospectively collected medical data on the national inpatient sample on outcome of 122,495 aneurysm repairs. Unadjusted perioperative all-cause mortality for open repair was significantly lower in high-volume surgeons who did at least 14 cases a year than surgeons with lower volumes. There was no difference following endovascular repair. High-volume hospitals also had significantly lower mortalities after open repair. The difference was less after endovascular repair, although it was still significant. After adjustment for patient comorbidities and hospital volumes, surgeons' volume was strongly associated with mortality after open repair. Hospital volume was also significantly associated with mortality, so the authors recommend that open aneurysm repair should be performed by high-volume surgeons in high-volume hospital. This is a strong recommendation with a level of evidence that's moderate. The next paper is our CME paper this month. It's entitled Targeting the Most Important Complications in Vascular Surgery. It comes from the Department of Surgery in Madison, Wisconsin, authored by Kyla Bennett and her colleagues. This study was conducted to identify the most clinically relevant and costly perioperative complications occurring in vascular surgery patients. Bleeding and stroke were the most frequent complications after 32,262 carotid endarterectomies from the NASQIP database, and bleeding, surgical site infection, and pneumonia were the most important complications after 40,130 abdominal and lower extremity vascular operations. So the authors concluded that quality initiatives that can successfully reduce postoperative stroke, bleeding, and pneumonia will have the greatest clinical impact on the outcomes of vascular surgery patients. But initiatives that target complications such as venous thromboembolism, urinary tract infection, or myocardial infarction will have little impact on outcome or resource utilization in vascular surgery patients. The final paper comes from the Beth Israel Deaconess Group, authored by Jeremy Darling and colleagues. It's entitled Predictive Ability of SVS Wound Ischemia and Foot Infection Wi-Fi Classification System after First-Time Lower Extremity Revascularizations. This retrospective single-center study uses a real-world sample of 992 patients with critical limb ischemia to test whether the SVS Wi-Fi classification predicts major amputation after first-time lower extremity revascularization. Freedom from major amputation was significantly lower in Wi-Fi stage 4 than in lower clinical stages, but the differences were more significant when a novel Wi-Fi composite score substratification was used. Freedom from reintervention, amputation, and stenosis events were better predicted using this new novel Wi-Fi composite score system. Thus, the authors suggest that we use the Wi-Fi mean composite scores to predict limb outcomes after revascularization. These were just a few of the many excellent articles from our March issue. To access these articles free on your iPhone, Android, iPad, laptop, or desktop in March, please visit us on www.jvassearch.org. Enjoy reading all JVS journals, and see you next time for the highlights of the April issue of the Journal of Vascular Surgery.